Hello, this is Christian Perring, and this is going to be the audio for a slideshow on psychiatric ethics. The slides will sometimes contain URLs. I will add the URLs to the YouTube comments, and I will try to keep this relatively kind of swift, although there is kind of like a lot to say. So um, let's hope I can keep it swift. So this slideshow is on psychiatric ethics, which is a little neglected, I think, within medical ethics. But it's certainly a very important area, and so deserves a lot of coverage. This slideshow is not going to cover everything by any means, but it's going to cover some of the most important issues, and I'll try to at least allude to some of the other issues that come up. So this is just a list of some of the distinctive issues in mental health from an ethical point of view, and that yeah, so the question is, how does psychiatry differ from other parts of medicine? And these are some of the issues. So I think probably the most obvious one is that there's a stigma to being called or being diagnosed or being labeled as mentally ill, mad, crazy, nuts, and so on. People who get those labels have a stigma attached to them, which means that they get labeled, well, they're seen as lower, as seen as troubled, and they are not generally seen as having all the qualities that deserve respect. So they get disrespected. All right, so that's a major issue. So it becomes a big issue. Who gets labeled as being mentally ill? And then we start to try to work out, well, what are the boundaries of mental illness? What do we mean by mental illness? And we're going to see that it's pretty vague. Exactly what counts as a mental illness is not very well determined. It's pretty subjective. Different people have different opinions, and it's complicated. Um, Another huge issue when it comes to psychiatry is working out what is a medical treatment for the benefit of the patient and what treatment isn't really for the benefit of the patient, rather it's for the benefit of other people, for the benefit of the person's family, their local community. Uh, so the idea is, if it's just behavior control, then you're just doing something in order to make other people's lives easier, which may be a perfectly valid goal, but we should at least be clear about when we are doing that and stop pretending it's really medical treatment. Another huge issue in psychiatry is that a lot of treatments in psychiatry have been terrible. They've been painful. They've been humiliating. They've caused a lot of medical harm. They've killed patients. And so psychiatry seems especially prone to treating people badly through the treatments that it gives. Uh, I mean, it's not as if the rest of medicine doesn't also do that. And obviously, some treatments in psychiatry are helpful. But if you look at the history of psychiatry, it is problematic. So that raises a lot of questions. And certainly, there's been a long history of treatments which are not just, well, they may be dangerous, but especially they're bogus, and they are, doctors promise that their treatment is going to work, and it doesn't work. So there's a long history of treatments which basically are there for the benefit of the doctor and not for the benefit of the patient. So that raises questions about, well, people claim to be experts in mental health, but and obviously they have medical degrees, they have specialities, they have training. But I mean, to what extent can we really think that they have a lot of expertise? I mean, is there such thing as expertise in mental health, or is it just a bunch of opinions? So all of these issues together make mental health treatment especially prone to ethical analysis. So this leads us to the question of what is psychiatry? Psychiatry is definitely a medical form of treatment, although exactly what we mean by that is going to be a little bit up in the air. So it doesn't necessarily rule out a whole lot, um, but uh, it's a branch of medicine. And so what does it cover? Well, it covers neurological problems. And then there's a big overlap with neurology. So I guess we think of problems like Alzheimer's, strokes. Uh, those are neurological problems too. So there's clearly something wrong with somebody's brain. And the prevailing assumption of psychiatry is that it deals with brain problems. Although, to be honest, how often does a psychiatrist actually look at somebody's brain? Almost never. So, it's kind of a little bit of a question exactly how much does it really involving brain understanding? It does with other stuff, but the brain seems to be involved in some way. Then there are cognitive issues, people like not understanding the world properly. Um, and we might think of also people who have various kinds of reading disorders or writing disorders, learning disorders. They're cognitive too. So there's an overlap between that and psychiatry. But it's really in the last two that we kind of think of psychiatry as being what it centrally is. People who have behavioral problems, which is people who can't run their lives in a way which works. And that's pretty vague. Exactly. I mean, lots of us can't run our lives in ways which work great. And it seems like some people are actually pretty good at running their lives, but they still have problem behaviors. So, exactly what we mean by a behavioral problem is going to need a lot of focus. But at least it's kind of helps us get some idea. And then the related idea is people have emotional problems, people who have very strong emotions, or maybe don't have the right emotions, or have a lack of emotions, um, and people who aren't able to control their emotions. Although lots of us can't really control our emotions, does that mean we have mental disorders? There's a lot of vague issues here, and that's just part of what psychiatry is. But those are the things which sort of are the central focus of psychiatry, at least. So who treats these mental health problems? Uh, well, here's a list: psychiatrists, doctors, neurologists, psychotherapists, and social workers. Neurologists will treat a very specific portions which can problems which can be identified through brain scans, and maybe through brain surgeons. I guess we could add to this list brain surgeons. Um, but I mean, those are not necessarily the problems which we really see as psychiatric or even mental health. They're on the side there. So it's really psychiatrists and doctors, psychotherapists, and social workers. Psychiatrists tend to kind of see people one-on-one, maybe occasionally in families, and they're meant to have a lot of specialization. Just general doctors, they have less specialization, But a lot of mental health diagnosis is done by doctors. A lot of people never actually get to see a psychiatrist, and they'll just get diagnosed with depression or anxiety. They'll get prescribed a medication, and that'll be it. Sometimes people go to psychotherapists, and they'll engage in talk therapy. There's various kinds of talk therapy, and that will be a way to kind of deal with the mental health problems, either in conjunction with something like medication or as an alternative to medication. Then there are social workers. Social workers, sometimes they do psychotherapy, sometimes they address problems in a more social way. They look at the problem in their family, they look at the kind of their community context, issues with work, issues with school, and they'll try to address the problems that people are having through that context and try to get to change what's happening there. So all of this centers around the issue of what kind of problems, what kind of conditions count as mental health problems. When should somebody get a diagnosis? And as I've been making pretty clear, there's a lot of vagueness around that, although there are also a lot of clear cases. Obviously, people experience all sorts of difficulties in life. Life is complicated, life is hard. People are failed by their families sometimes. People have traumatic experiences, and so they have a hard time. And sometimes people seem to be born with conditions which mean that they have a especially hard time. So the question is, like, when should people get diagnosed as having a mental illness? Some of the central idea of a mental illness seems to be that there's something wrong with that person. Something kind of internal to that person is wrong with them. Exactly what kind of problem it is has to be investigated, but it's something wrong with them and something which needs to be fixed. There was a book back in the 1990s by Nancy Andreasen, I think it was, called The Broken Brain. That really encapsulated this sort of idea there's something wrong with somebody, their brain is broken. But it often turns out that it really what's going on is a sort of mismatch between the person and their environment. They're going through difficult times. They're going through a shitty situation, and they are having difficulty coping with that. So when you kind of think of issues that lead to mental health problems, there's issues like stress and depression, people experiencing intolerance, people experiencing trauma, having a sense of fragility, not being able to cope, and often having a lot of anger around that. Those are kind of classic issues, and they all seem to be related to mental health problems. So that means it's pretty much it's kind of hard to say when something is really wrong with a person and when it's a mismatch between them and their situation, or if their situation was better, then they wouldn't have a problem. So that's a big issue there. We're very familiar with the idea that if somebody is competent, then they're able to run their own lives. If they're not competent, then they don't have that ability. So there's a very strong link between competence and autonomy. So there's a question, can people with mental illnesses be competent? Can they run their own lives? And the answer is obviously sometimes they can, sometimes they can't. If somebody is having delusions and they think that they're Jesus Christ and they are out there trying to kind of perform miracles, then that seems like they're really not able to run their own life. On the other hand, if somebody has a bit of depression, and they're kind of struggling with it, maybe they're undergoing some treatment, then probably they can. Maybe occasionally there's times when they need some help, but they have the ability to run their own lives. So definitely seeing people with mental health problems can often think for themselves in a rational way, and it all depends on how extreme the problems are. It's also worth noting that a lot of mental illnesses are episodic, especially things like manic depression. That is kind of comes and goes, and a lot of mental illnesses come and go. So sometimes people may be more competent than other times. Uh, we've seen there are no sharp criteria what counts as being competent. So there's a lot of gray area when we're looking at autonomy, and that's going to be especially true when it comes to mental illness. And there's a lot of subjectivity in exactly, how do we decide whether somebody is competent? Um, so we should be very careful in assuming that people with mental illnesses are not competent, are not able to run their own lives. Now we come to one of the kind of central ethical issues in mental health, that of involuntary hospitalization. When is it reasonable to put somebody in a hospital against their will? And that's been a big issue for a long time. So we're going to go through this in a fair amount of detail. Uh, so obviously, people have a right to run their own lives normally. So if you're going to take away that right, you have to have a very strong reason to do so. Uh, One thing especially to note is that you don't necessarily have to kind of force somebody into a hospital. Um, there are ways to encourage them to go to mental hospital. And I guess then there's questions about to what extent is that coercive or is it not coercive. Now, you can bargain with somebody. You can say, like, if you go into a mental hospital, then we'll work with you. We'll give you what you want. If you don't go, then um, you'll make their lives more difficult, uh, or you'll be unable to really help them in some ways. So that's a kind of bargaining. There may be other kinds of bargaining too. To what extent that's coercive, it partly depends on what's going on. Um, it's pretty common to say to somebody, look, go in voluntarily. If you don't go in voluntarily, then we'll force you. Uh, Now, is that very different from forcing somebody? It seems very close to forcing somebody, but it kind of gives them a different legal status. They've officially gone in voluntarily rather than involuntarily, and that often gives them more rights. But it seems very close to forcing somebody. And then there's different forms of threats. You can threaten withdrawal of support if they don't decide to get treatment. You might threaten to take away their kids, or they'll lose their job. They'll get reported. There's all sorts of threats you can make if somebody doesn't get treatment. That can push them to get treatment. And conversely, you can promise benefits or support if they do get treatment. Those are all ways which are not quite the same thing as involuntary hospitalization and detainment, but they are kind of close. So it's good to be aware of those differences. There are also differences between putting somebody in a hospital and treating them. Obviously, those two things tend to go together. If somebody goes into a hospital, they tend to get treated. But it is possible for somebody just to go into a hospital and not get any treatment. That's just like a confinement. In some ways, that's a sort of just an imprisonment. But and according to the law, there's two different things: forcibly detaining somebody and forcibly treating somebody. So it may be that there are reasons to forcibly detain somebody, but not to forcibly treat them. So you have to be aware of that sort of subtlety and complexity. In New York, and it's different for different states, involuntary medication is legal for adult patients in an emergency where there is an immediate danger to the patient or others around them, or on an ongoing basis after a court finds that the patient lacks the capacity to make decisions about their treatment. So those are the cases where medication can be forced on a person. In New York, we have Kendra's law. Other states have their own versions of Kendra's law, which is not about forced medication. Kendra's law does not mandate that patients be forced to take medication. Rather, it's about forced outpatient treatment. So it means that patients have to kind of consult with mental health professionals on an outpatient basis, not in the hospital. So the law grants judges the authority to issue orders that require people who meet certain criteria to regularly go psychiatric treatment. And if they don't do it, then they can be committed for up to 72 hours and then maybe longer. So Kendra's law is a kind of a special feature of New York State, which makes the issues a bit more complicated. So there's a big question here, like the idea of forcing people into treatment, into hospitals, forcing them to take medication. When can you do that? Obviously, one of the big ideas there is that mentally ill people are dangerous, and they need to be kind of locked up. They need to be treated. But is that really true? And the evidence that mentally ill people are actually more violent than others is it's not necessarily shaky. There are some cases of very violent mentally ill people, but then there are violent people who are not mentally ill. The question is, does mental illness really make you more violent? There is an estimate that psychiatric disorders are responsible for 7 to 10% of murders. Exactly whether that's kind of reliable information or not, sometimes these stats don't really turn out well. There have been assessment studies which found that the majority of civilly committed patients were not violent in the year following discharge. So it seems we have to be careful in assuming that mentally ill people are violent. It seems like, well, actually, that may not be true. Maybe the issue is just violence. And so assuming that mentally ill people are more violent is a big problem. What happens if somebody is put into a mental hospital against their will? Well, obviously they lose their freedom for a while. Maybe society is safer, but there are other consequences too. They lose their rights for legal gun ownership, at least in some states. I guess that's disputed in others. Certainly, it can mean immediate job loss for law enforcement professionals or those in active military duty. Presumably, other people could also lose their jobs if their bosses find out that they have been locked up in a mental hospital. Certainly, if you are locked up for a while and you're looking for a job, then it may be more difficult to get a job if you tell a prospective boss that you've been in a mental hospital. This goes to the issue of stigma, which we were talking about before. So certainly there can be strong negative consequences for somebody who's gone through this. It's also worth noting that unless somebody has either they're fabulously wealthy or the state pays for all of their medical bills, generally they are going to end up with high medical bills. They may have to file bankruptcy if they can't pay. And often insurance may find a way to try and wriggle out of paying further as medical bills, or will only cover a portion of it, and the person is left with a high cost. So it can be, crippling in terms of finances to be in hospital for a long time. So we have to be aware that it can be very serious consequences of putting somebody in a mental hospital. Also note that putting somebody in a mental hospital can be a risky thing for the person emotionally and physically. Being locked up in a mental hospital, sometimes it works out really well and the person benefits, but there's also a danger that it can be traumatic. It can be emotionally difficult to be in a mental hospital because you're surrounded by other mentally ill people, and it can be a very kind of unsafe place. And you see media depictions of this all of the time, really. Um, Also, involuntary treatment often begins with a call to the cops. So having the cops kind of come to your place or your place of work and take you to a mental hospital, that's not going to be a good experience either. And it can be sometimes that just the whole process of being detained and going to the hospital can be end up with violence. There can be resistance, so it can be pretty hard. Sometimes people end up dying when confronted by the cops like that. It is estimated that about a quarter of the individuals killed by police officers responding to emergency calls suffer from a mental illness. So it does seem that there's some link between being killed by cops and being mentally ill. It is often reported that people who end up being detained in mental hospitals forcibly find the experience of being put there and kept there uh, traumatic, and they experience that as an assault. So often they're held down by guards, they are injected against their will with sedating medications, and so basically it feels like they're being assaulted. Even patients who are initially calm may become agitated as a result of the experience. They find it humiliating. They're told to remove their clothing. They have to kind of have their blood drawn, or they're forced to take medications, and they just find this extremely difficult and unpleasant and degrading. And some patients find that having their freedom taken away and having their mental health questioned uh, is kind of itself traumatic, even if they haven't experienced any physical restraint or kind of been put in solitary confinement. So it's a pretty kind of bad experience to be put in a mental hospital, or at least it can be. All this means that the decision of whether or not to involuntarily hospitalize somebody is an extremely difficult one. There may be benefits. It may be that it's the only kind of option left, because somebody's family doesn't want to deal with them. They seem like a danger to themselves or others. They seem like they're just kind of living in ways which are socially unacceptable. And so, you have to kind of put them away in some institution. But it can, but that may not necessarily be for the health of the patient. It may be for the health of society. Uh, it is worth noting that the main risk factors for somebody being violent are having a history of violent victimization, them being abused as children, and their own past violence. So those are the main factors for whether somebody is going to be violent or not. Having a psychiatric diagnosis doesn't seem to actually make much difference in the risk factor of somebody being violent. It's also worth being clear that there's actually very little expertise. It's very hard to predict when somebody is going to be violent or if somebody is going to be violent. So it means that if you you don't really know whether somebody's going to be violent or not, and you're looking people up, it means that you will end up looking people up who would never have been violent. And so, there's a high cost to this decision. It doesn't necessarily mean the decision's wrong, and if you don't know what the future is going to be, then you just have to go with the information you have. But it's definitely a very important decision, and one should not be taken lightly. And the consequences for people who are locked up can be very serious in all sorts of ways, including financially. Uh, I would point you to the work of Ellen Sachs. Ellen Sachs is a law professor, and she discusses the ethics of involuntary hospitalization. What's especially interesting about Professor Sachs is that she herself has a diagnosis of schizophrenia, and she has experienced being locked up in a mental hospital against her will. So she provides a valuable perspective. And so she has both legal expertise and personal expertise in that. So I would strongly recommend looking at her work. It's worth noting that a lot of the discussion regarding involuntary commitment is especially relevant to New York City, which has a lot of issues with unhoused people with mental illnesses and how they are affecting the city. And Mayor Adams has made steps to put more of those people in mental hospitals or other places, either kind of with their cooperation or without it. So, and there's a question, I guess, about whether that's what those people really want and whether the effort is to actually help the people with the mental illnesses, or whether it's just to clean up the streets and make New York City look less scary to tourists and also to the residents. So that's a big issue. So there's a link here which I'll provide in the comments to the ethics of involuntary commitment and laws that protect the mentally ill in New York City. Another major issue in psychiatric ethics and mental health ethics is to what extent material or information that's exchanged between a healthcare professional and a patient is confidential. So that's certainly relevant to issues in other areas of medicine regarding infectious diseases, for example. But in a session and where two people are talking, they will exchange sensitive information, and sometimes that information will be about kind of violence or abuse, and there are questions about to what extent healthcare professionals should keep that information confidential. So let's talk about that. Uh, you know, we know there are general expectations that patient information should be confidential. There's a right to privacy. Um, However, things are a bit more complicated these days because there is so much online information. Information is stored in computers and the cloud, and all sorts of people have access to that information. And I think just about everybody is familiar with the HIPAA Act of 1996, which regulates a lot of that information. That's kind of now coming up to nearly 30 years old. I think it's been updated a bit, but still the basic idea is, there are a lot of concerns about how to keep information regulated. So why is information especially sensitive in mental health? Well, it's reasonably obvious. There's a lot of stigma attached to mental illness, and people reveal sensitive information about themselves when talking to mental health professionals. Sensitive in the sense that they don't want other people to know it, and also that as I mentioned before, it may involve abuse and violence, and so uh, you know, it's especially sensitive. Another huge factor in mental health, I mean, this is true in medicine generally, but especially in mental health, is that you need to have trust between a client and a therapist. For the treatment to be effective, especially if there's some element of talk therapy, but you need to have a client who's able to open up to the person they're talking to. So, I mean, the main tradition in mental health is that details of treatment are kept very secret, and that they're never revealed to anybody else. That may include information that some people think should be public. So there is plenty of debate about this. The best known case regarding confidentiality is way back 50 years ago now. Tarasov versus the Regents of the University of California. You had a one person who killed Tatiana Tarasov. That person told his therapist he wanted to kill Tatiana Tarasov. The therapist, who was employed by the University of California, told, I think, the campus police about it, but not the kind of local law enforcement. Well, after he killed Tatiana Tarasov, the parents, I think they sued, or they sued the University of California, and basically the legal case was that the court decided that therapists have a duty to warn third-hand parties of foreseeable harm. Now, exactly what foreseeable harm means is a tricky issue. I mean, do we know what people are going to do for sure, or is it kind of just reasonably foreseeable? That's a big issue. But there is basically the idea that healthcare professionals have a duty to protect intended victims of violence. One of the major issues is that it's very hard for anybody to know what anybody else is going to do. I mean, you may be worried what they're going to do, and there may be a danger of that, but our ability to actually predict dangerousness is not great. And it doesn't seem that psychiatrists are particularly good at predicting violence. So if you're not really sure what's going to happen, then that makes it much more difficult to know when you should warn somebody that they may be subject to violence. If every time uh, a patient said, I really want to kill that person, a therapist had to warn that person, there'd be a lot of warning. Generally, there's a big difference between saying something and actually doing it. That's a big issue. Our final section in this presentation is about the history of psychiatry, and I guess especially about the history of kind of the bad treatment of patients. So let's talk a little bit about that. Uh, there's a lot of history of people proposing treatments, which now we think of as kind of barbaric. And these treatments that happened, especially in the kind of 20th century, not also there's kind of ones earlier than that, but I guess it's especially relevant to think about the 20th century, which is not that long ago. So here's a list of some of the treatments that were done and some links. There were things like insulin shock therapy, chemical shock therapy, lobotomies, and kind of all sorts of treatments which we would think of as being kind of just terrible. And you wonder, like, well, why did those people think that it was a good idea to treat patients in those ways? Um, and it seems like, I mean, there's a question about to what extent the doctors really cared about the patients rather than their own careers. But it seems like they did genuinely think that these treatments could be helpful. So they were, and not only that, they thought they had sort of scientific proof that it was helpful. Uh, so there's a kind of question about how could they have thought of that and have things changed? One notable example is electroshock treatment. Uh, Probably the most famous depiction of electroshock treatment is in the movie with Jack Nicholson called One Flew Over the Cuckoo's Nest, a classic from the 1970s, I believe. Maybe it was the 1980s. Um, and So electroshock treatment was used for a number of conditions, and the idea was, in some ways, the idea was that you reset the brain or something like that. Um, and it was used extensively. Uh, so there's a kind of still a lot of debate about electroshock treatments and the kind of putting electrical currents through people's brains. Uh, It does seem that it is a pretty effective treatment for people who are suicidal. That if no other treatment is working, and somebody is really in danger of killing themselves because they're so suicidal, then doing electroshock treatment can actually help them. Yeah, one of the big questions is, well, what effect does it have to do electroshock treatment apart from the helpful ones? Does it have any do any damage? And there's debate about that. Some psychiatrists say there's no good evidence that it's harmful, and so it should be perfectly good form of treatment. On the other hand, critics say that it's especially bad for memories, that people who go through electroshock treatment lose a significant number of memories, and that's kind of upsetting if you can't remember important things. Um, the other kind of thing to think about is, like, how was this treatment used? Was it really used as a way to help people, or was it used in healthcare settings, especially in hospitals, as a way to punish patients who were behaving badly? So it's a form of behavior modification. There's a link there to some of the history, and there are plenty of books about it. Definitely worth investigating. So my sort of general question and final question is, should we think, oh, those were the bad old days, and now we're much more enlightened, and we would never do those kinds of things again? Or on the other hand, should we think, actually, psychiatry hasn't really changed very much. Maybe the different kinds of treatment have changed, but the basic kind of approach of scientists being convinced that their solution will work, when in fact it doesn't really work, or it has a lot of bad side effects. Have things changed that much? And obviously psychiatrists like to think that they are on the side of the good, and they're beyond reproach, and that things are all just great now. But there is a considerable considerable movement which critiques modern psychiatry and says it's not really about helping people, it's about behavior control, controlling people who are considered difficult. It's about making money for psychiatrists, it's about making money for pharmaceutical companies, and that modern psychiatric techniques are not really a whole lot better than they were 100 years ago. Now you'd think that that we could resolve this by kind of good scientific experiments or scientific observation, and just have numbers about whether things really have improved. I think if you look at those numbers, it seems actually that a lot of treatments are not much more effective now than they were 50, 60 years ago, maybe even beyond. I think that there's room for continued debate about this. And it's a kind of an essential issue for thinking about how ethical is it to practice psychiatry, and what ways should be used, what treatment methods should be used. So I think it's the history of psychiatry is directly relevant to understanding mental health ethics.